Welcome everyone to this year's EULAR Congress highlights on psoriatic disease. My name is Lourdes Perechada. I am a dermatologist. I work as a clinical researcher at the Brigham and Women's Hospital, and I will be moderating this session with Fabian Proft. Hello, Fabian.
Hi, Lourdes. Pleasure being here with you today.
So I can see that many people are joining. So in the interest of time, we will get started. So for those of you who have participated in other iterations, thank you for coming back. And for those who are new, thank you very much for joining. This is a very exciting activity from GRAPPA that we started last year, in which we summarize the most important findings related to psoriatic disease at the major dermatology and rheumatology conferences. And these are the EADV, AAD, EULAR, and ACR. In this occasion, we will be discussing the abstracts presented at the 2024 EULAR meeting, and we will have 3 young GRAPPA members who have been supervised by 3 senior members from GRAPPA presenting on 3 specific topics. So on treatment updates, on basic science, and on clinical topics. So now I'll hand it over to Fabian to walk us through the agenda for today.
Yeah, thank you, Lourdes. As you have already said, my name is Fabian Proft. I'm also a rheumatologist working here at the Charité in Berlin, and it is my real pleasure to be here with you guys and hear the topics that have been selected in cooperation of the young GRAPPians together with senior GRAPPA members of the highlights of the specific sections that were presented last week or the week before in Vienna, where we met for the EULAR conference. And I think it is just incredible to have the opportunity to see the short bits of highlights that have been selected, and especially also have here interdisciplinary discussion between dermatologists, rheumatologists, and also to include the PRP perspective. So without any further delay, I think we can just get started, and here are our disclosures without any, because we were not involved in the selection of the abstracts, any influence on the current topics. And as said, the agenda, we will start with the treatment highlights today, and then we will go over to clinical topics and then finish with the cherry on top with basic science. And we will go first where Sebastian Herrera and Laura Coates have prepared the highlights for treatment. And I think we can directly get started. Sebastian, the stage is yours. Sebastian is a very active member of Young GRAPPA. He's leading our social media subgroup, and he's a driving force of our organization. And he has been supervised by Laura Coates, one of the real PSA experts that we all are very familiar. Laura led the just recent treatment, GRAPPA treatment recommendations update. And congratulations also for being newly elected to the GRAPPA board of directors. Yeah, and without any further delay, Sebastian, the stage is yours. We are looking forward to your presentation.
Hello, everyone. Good morning, good afternoon, good evening from wherever you're joining us. Thank you, Fabian, for this introduction. It's a pleasure to be here today, reporting the treatment highlights of psoriatic disease from EULAR 2024. I want to thank everyone at GRAPPA that made this possible and for giving me this opportunity to participate. And I also want to thank Dr. Laura Coates, whose work, guidance, and knowledge was made this presentation possible. Let's go to our disclosures. These are our disclosures. And let's go to the next slide, to the TRINEX cohort. So there's an important background for this work. There's a need for early detection and opportune treatment with psoriatic disease. There are disparities between joint and skin response, and diagnostic delay of PSA comes with poor radiographic and functional outcomes and less probability of remission. PSO usually precedes PSA, and we have conflicting evidence with prospective and retrospective data about PSA interception in PSO-treated patients with DMARDs, both synthetic and biological. And they're adding to this controversy, there's also some evidence that suggests that there might be a difference between biological DMARDs regarding the risk for PSA in patients treated with biological DMARDs, mainly IL-12/23 inhibitors, IL-23 inhibitors, when compared with TNF inhibitors. So the objective of this report, of this work, was to evaluate the incidence of psoriatic arthritis in patients treated with different biological therapies for moderate to severe psoriasis as a first and second biological. And the great question is, Was there any difference according to the mechanism of action? With the methods, PRINEX is a global research network with presence in about 30 countries in Europe, USA, Asia, and Latin America. It has analyzed data for about 200 million patients, and they selected PSO patients without arthritis from 2010 to December 2023. They grouped the patients according the PDMARD mechanism of action, and patients who changed treatment were censored. The cohorts were adjusted for sex, time since diagnosis of psoriasis, obesity, alcohol and tobacco use, nail psoriasis, and DMARD use. And the incidence of psoriatic arthritis was compared in the cohorts using TNF inhibitors as a comparator in first line using RR and HR. They had around 5,000 patients in each group, being either IL-12/23 inhibitors, IL-17 inhibitors, and IL-23 inhibitors. And the data for relative risk was reported for naive patients who initiated IL-12/23 inhibitors and IL-23 inhibitors with risk at 5 years that they found was 34% lower for patients with IL-12/23 inhibitors and 60% lower in patients that initiated IL-23 inhibitors when compared to TNF inhibitors. When evaluated as a second line, the risk of PSA at 3 years was calculated as 24% lower in patients starting IL-12/23 inhibitors and 40% lower in patients starting IL-23 inhibitors at second line when compared with TNF inhibitors as a first line. When they compared IL-23 inhibitors versus IL-17 inhibitors, there seemed to be a lower risk of PSA at 3 and 5 years, both as a first line, they found a 55% less risk, and as a second line, they found a 45% less risk when compared to IL-17 inhibitors. There are limitations to this study, and we have to keep those in mind. It's an observational and retrospective study, so there's always a bias risk. There could be an indication bias. There might be possible coding mistakes, although they mentioned that they tried to correct for those and they surveyed for those, but there's always the possibility. We don't know the influence of non-biological DMARDs in this cohort, at least in this report. We don't know the influence of the activity of this disease, at least in this report, and we don't know the reasons for biological interruptions in this report. So we have to keep in mind these limitations, because there are also strengths that are really important. It's massive numbers with a long-term follow-up. The cohort was adjusted for multiple confounding factors, but there are some PSA risk factors that were left out of this adjustment. And although this adds to our current knowledge and is in tune with recent publications, we have to take the data as it is. It's retrospective data. It could have bias because of the nature of the data, but it adds to our current knowledge. Definitely, we eagerly await more data regarding the complete report and also the results of RCTs that are currently ongoing for this topic. So this was the TRINEX. It made a lot of waves during the ACR, during the EULAR. Now let's go to the STAR study. So the STAR study is really interesting. We are also waiting more data for this study. A little bit of background. We don't have a validated classification criteria for actual involvement in PSA. STAR is a phase 4 multicenter RCT of biologic naive PSA patients with current spinal pain and MRI confirmed actual inflammation. And it's prospectively evaluating efficacy of guselkumab on actual symptoms and objective measures of actual inflammation in MRI. The objective of this report was an exploratory analysis of available screening MRI data from the STAR cohort or the STAR patients, comparing clinical characteristics between patients meeting and not meeting the MRI eligibility criteria. They had information, they plan to randomize 405 patients to either guselkumab 4 weeks, guselkumab week 0, week 4, and then every 8 weeks, and placebo going to guselkumab at week 24. The eligibility criteria for the STAR study, it's an active PSA with 3 or more swollen and tender joints, C-reactive protein equal or greater than 0.3 milligrams per deciliter, despite non-PD marks, apremilast, and or NSAIDs. As I mentioned before, patients must be PD mark naive, and they must have a PASDI either 4 or greater than 4, with a screening MRI with a confirmed positive result for inflammation, defined as a centrally read spot score of 3 or more. So the patient's clinical characteristics and medical history were documented as screening, and they were compared between the MRI positive and the MRI negative cohorts for inflammation, and they determined those associated with MRI-detected inflammation at the sacroiliac joints and the spine. So they screened 487 patients. Of these, 459 had information for the sacroiliac joints. 34% of these had a positive MRI for inflammation at the sacroiliac joints. 461 patients had information for the spine MRI. 30% of these had inflammation at the spine, and 433 patients had information for both the sacroiliac joints and the spine. Only 15% had both a positive sacroiliac joint and spine MRI, and 59% had a negative sacroiliac joint and spine MRI. Important data from the STAR study. The percentage of males and CRP levels were significantly higher in both the sacroiliac joint positive MRIs versus the sacroiliac joint negative MRIs, and the spine positive MRI versus the spine negative MRI cohort. The patients with a positive sacroiliac joint MRI for inflammation were characterized by a younger age, with a mean of 44 years versus 47 years, a higher spinal pain score with a mean of 7.7 versus 7.3, although personally the magnitude in this difference seems to be small, and fewer tender joints with a mean of 12.6 versus 15.5 versus the negative sacroiliac joint MRI cohort. There were also numerical difference between the spinal pain back score and the tender joint counts between spine positive and spine negative cohorts, but they did not achieve any statistical difference. The positive sacroiliac joint cohort comprised numerically higher patients with a history of inflammatory back pain, nail psoriasis, and scalp psoriasis when compared with the negative sacroiliac joint cohort. And also something interesting, the history of palmoplantar psoriasis appeared less likely to exhibit MRI-detected inflammation in the sacroiliac joints or in the spine. So we eagerly await more data from the STAR study, but we start to get a picture of what's going on, at least with the clinical characteristics. Now let's continue to the ARGO study data. The ARGO study data is really interesting. It's data from the phase 2A study. Sonelokimab is a nanobody whose structure is based on a cameloid antibody. It dually binds IL-17A and F. It has a smaller size, so that's why it's called an antibody. And there's a theory behind this that there might be an impact regarding distribution and pharmacodynamic effects due to its size. So this report is the 12-week data of the ARGO study, which is a 24-week study. The eligibility criteria for the study was at least 3 swollen and tender joints, currently active PSO or a dermatologist-confirmed PSO diagnosis. Patients were stratified according to sex and prior biologic use. Around 15 to 20% of the patients had used a PDMAR. And the primary endpoint was an ACR 50 response at week 12, taking into account sonelokimab versus placebo, and a PASI 90 response at week 12 in a subgroup of patients whose PSO involvement was at least 3% of the body surface area or greater. The intention to treat and non-responder imputation as a primary analysis, and they also had a multiplicity control analysis of primary and key secondary endpoint. So they also had an adalimumab reference arm, but not for statistical comparison. The baseline characteristics of the patients were well balanced. The BMI was around 20 to 30, and around 3/4 of the patients were receiving methotrexate. So for the results, they had information for 207 patients that were randomized. The discontinuation rate was low, around 4%. And they had a placebo group, a 60 milligram sonelokimab group without induction, 60 milligram group with induction, 120 milligram group with induction, and as I said before, the adalimumab reference group. Argo met the primary endpoint of ACR 50 at week 12. 20% of patients with placebo met ACR 50. 36% of the patients with sonelokimab 60 milligrams without induction, 46% of the patients with sonelokimab 60 milligrams with induction, and this had a statistical difference with the placebo, and 46% of the patients with the sonelokimab 120 milligrams with induction also being statistically having a statistical difference with the placebo. Key secondary endpoints for skin, PASI 90 was 15% for the placebo, 50% for the 60 milligram dose without induction, 76% for the 60 milligram dose with induction, and 59% for the 120 milligram dose with induction. Onset of response was rapid, with improvements versus placebo observed by week 4, ACR 20. They also checked for more stringent criteria. NDA at week 12, only 12% of the patients with placebo obtained an NDA at week 12. On the 60 milligram without induction of sonelokimab, only 26% obtained an NDA, but in the 60 milligram group, 43% did obtain an NDA, and the 120 milligram group, 37% obtained an NDA. And in the combined outcome of ACR 50 plus PASI 100, only 7% of the placebo patients obtained this outcome, but the 60 milligram with induction patient group obtained that 30% of the patients obtained this outcome, and in the 120 milligram with induction group, 33% of the patients obtained this outcome. This correlated with measures of quality of life, including wide range items that were captured by PSA-12. The medication was well tolerated. There were no unexpected safety findings. They reported 2 cases of oral candidiasis that didn't lead to discontinuation of the medication. No cases of MESAs, no cases of IPD. But we have to take in mind the short exposure time to sonelokimab on the 12-week data. So safety and efficacy seems similar to what we know with other IL-17 inhibitors. We must remember this is a dual inhibitor, and this data supports further exploration in phase 3 studies for sonelokimab. Is there an added benefit to nanobodies? We don't know yet. And if we do find an added benefit with sonelokimab, will it be because of the size or because it's a dual inhibitor? So we eagerly await more data. And now to our next slide. These are honorary mentions. Unfortunately, time is short. I suggest for you to go and look for them either in the abstract archives and in the recorded sessions. The first one is a report by Dr. Kievitz. This is TAC 279. It now has a name, sasucitinib. It's a TYK2 inhibitor, oral inhibitor. This is the report of the phase 2b trial in PSA, where they report that they obtained positive results regarding their primary objective, that was ACR 20 for the for 2 doses of sacituzumab when compared to placebo. They also had a dose response positive report for PASI 75 when compared to placebo. And the other 2 reports are by Dr. Schiff. One's real-world data report for treatment persistence of guselkumab in PSA compared to IL-17 inhibitors, IL-17A inhibitors, and the other is a real-world data report of guselkumab persistence in PSA versus TNF inhibitors, subcutaneous TNF inhibitors in PSA. Both reports suggest a higher persistence with guselkumab, so you better go and check them out. We have to keep in mind the potential bias because these are retrospective reports of databases, but they're interesting and they add to the current knowledge of what we're trying to learn about the position or where we should use IL-23 inhibitors in PSA patients. So this is all. This is the reports we had for today, and thank you very much for this opportunity. And once again, thank you very much for Dr. Coates for all her guidance.
Thank you, Sebastian. What a wonderful presentation. And yeah, as you said, time is short and there were really a lot of fantastic highlights about treatment and around PSA presented at the EULAR Conference. A very important message to all of you out there. You have the option to ask any questions in the question and answer. So please feel free to type in your questions and we would direct them to the speakers. I saw that Sebastian needed to leave, but he's back there, because now we can start with the panel discussion. And maybe let's start with your first abstract, because the Trinetics study really was, I think, was controversially discussed in at the EULAR already. I think it's great if you look at the numbers with almost 2 million patients, really incredible numbers, over 5,000 in the different treatment groups. A provocative question: will it change the guidance that we give our dermatologists? Should all dermatologists treat their PSO patients now with a specific mode of action to prevent PSA outbreak? What do you think?
So I would say no. I think, as you said, it's exciting to have this kind of data, to have those kind of numbers, and to be using this data to answer real world questions. But as Sebastian highlighted really clearly, there's so much channeling bias that it's difficult to say that these conclusions are useful or clinically relevant. It raises an issue. So it raises a possibility, and I think there's a lot of interest in this space. But at the moment, I would treat psoriasis patients how you want to treat them based on the evidence in psoriasis for now. Things may change in the future, but I think it really nicely shows that this might not have been the right question to ask because of that channeling bias. But look at the kind of data we have. You know, it's amazing to answer other questions where there's less of an issue of channeling bias, and having access to these kind of data sets is going to be really important for some real world evidence in the future.
Perfectly agree. And also because you were the second abstract were the STAR study. And I think here again, very important to highlight that this is the first study specifically an actual PSA, also including active inflammatory lesions by MRI as the screening being mandatory in the screening process. And because this also gives a cliffhanger to the ongoing discussion what actual PSA really is, and Daniela will present here also about the ACCESS study with the title, The ACCESS Study Gives Answers. So I think we can focus all the discussions around what actual PSA really is after we have the treatment session. But also here again, I wanted to ask you, Sebastian, how do you see it? Because it was mandatory that all patients included in the STAR trial needed to have at least 3 swollen joints as well. So this is also a specific population of PSA patients that really needed to have very active peripheral disease on top of their actual disease. And do you think this will also have an influence on the outcomes? Because we know that also here the BASDA is the primary endpoint, and we know that also effectiveness on peripheral disease will also influence the BASI. So what is your take on this?
Yes, definitely. Everyone who has an interest in psoriasis, in psoriatic disease, are eagerly awaiting both the SAR and the AXIS reports. Whatever we learn, whatever data we have, it's really important. Definitely, the requirement of at least 3 swollen and tender joints will have an impact of which people are recruited to the studies and the results. There's always the fear with the BASDI capturing peripheral data, and that patients that feel better with their peripheral symptoms might influence the BASDI results, and it might falsely skew the data on the actual symptoms that we're trying to evaluate, but still it's valuable data. We're going to go from not having an RCT to having an RCT with this kind of data, and it's the best tools we have at the moment. So we have to keep in mind that it's a really selected population with a really important peripheral compromise of the disease, but definitely it adds to our current knowledge, and it will definitely change perspectives in the future.
And we also have the MRI as a secondary outcome, so we will also get answers for the real influence on active inflammatory lesions, both sacroiliac joints and the spine, with guselkumab in patients with PSA and also actual manifestations, right? So I think it's great. Also, then you mentioned also the nanobodies, and did they also already announce what will they follow in the phase 3 program? So which dosage is the one that they are aiming for? Do you have an idea about this, Sebastian?
I failed to know which dose they're following. If my mind doesn't fail me, they didn't mention, although it's interesting because the data, you have a surprise that the 120 milligram dose sometimes it's a little bit lower than the results for the 60 milligram dose with the induction. So I think they might go the 100 milligram dose, but that's just me. Theoretically, I don't know, and they didn't say exactly during the oral presentation.
But this was also my impression. Laura, do you have any idea? Have you heard about it?
So I think it's still in discussion, and obviously it needs input from the regulators to work out what they will also allow. But I think there's still a question from the data that we've seen so far about the dose.
And there's also a question coming from the audience. Are there any early thoughts on how izokibep, another nano IL-17A antibody, might compare to sonelokimab? Do you have any idea, or I mean, this is just speculation?
Yeah, I mean, it's really tricky, isn't it? I think the big question, so sonelokimab is a nanobody, izokibep is a small protein. It's about half the size of sonelokimab, but izokibep's only R17A and sonelokimab is R17A and F. So they're all slightly different IL-17s, but at the moment, from the data that we've seen so far, and this is small studies and short follow-up, they look kind of like you would expect any other IL-17 to look. They don't look massively different. I think it will be interesting to see as we get more data, whether they penetrate certain tissues better, whether that translates into better outcomes, and kind of how they compare. But I think there are these differences in the way the molecules are made. What we haven't seen yet is whether that really translates into a different clinical outcome for patients.
Absolutely agree. And also for sonelokimab, were there any enthesitis data, Sebastian? Because you present the MDA, but I have not seen the specific enthesitis data. Was it presented?
In what I've seen, it was ACR, it was ACR50, the PACES, the quality of life data, the MDA, but I don't remember and I don't recall reading the enthesitis data.
Yeah.
Okay.
So
yeah, sorry.
that was looked at in the izokibep study, because they had really good phase 2 data and there was a question about whether it might be amazing for enthesitis because it was so little it could get into the tissue better. And it seems to probably work still in the Izokibep study, but it wasn't significantly different from placebo. So there's definitely a kind of, again, a lack of proof that this different approach really changes the outcomes. But we didn't have enthesitis data on sonelokimab presented at EULAR. I suspect because of the numbers, it's obviously quite a small study. Not everybody has enthesitis. It's harder to show a difference. So it focused much more on the joints, the skin, and the patient-reported outcomes, as Sebastian said.
Yeah, absolutely. And there's also a question from Rodolfo. Do you have any comments about the lower joint count in patients with MRI positivity of the sacroiliac joints from the STAR trial? What is your speculation? Can you share your thoughts on this?
I mean, I think it's an interesting question, isn't it? I think we need more data and more analysis to look at what this really means, and we've obviously got discussion to talk about the data from Axis as well. It would not surprise me hugely if we recruited a bunch of patients with predominant axial disease who have some joint disease but not lots of joint disease. I don't see huge numbers of patients in my clinic who have very active spinal disease and very active peripheral arthritis. So it maybe is a slightly different phenotype, but it's always tricky because we're more likely to pick it up when we're looking harder for it in the PSA patients.
Yeah, absolutely agree. This was also my thought and also our impression from here, but I think it will be so valuable to have better data and also specifically focusing on this specific patient population. So thank you, Sebastian. Thank you, Laura. It was a brilliant presentation and a short run through the highlights on the treatment session. And I think, Lourdes, we are ready to proceed with the next topic, if you agree.
Yeah, sounds great. Thank you both. Okay, so now we're going to be talking about the abstracts focused on clinical topics. And the young GRAPPA that will be presenting is Daniela Tovar. She's a rheumatologist and an internist from Lima, Peru. She is a young GRAPPA member, and she's also a member of Young PANLAR and coordinator for PANLAR Mujer. And she has been supervised by Denis Podubny, who is a rheumatologist and a GRAPPA steering committee member. And he just transitioned from Charité University Hospital in Berlin to University of Toronto, where he will be a co-director of the PSA clinic, following Dr. Daphna Gladman's footsteps. So welcome both of you. And Daniela, the floor is all yours. You can take over whenever you're ready. Thank you.
Hello, everyone. Thank you so much for your kind introduction, Lourdes. I'm very excited to present some of the highlights from the recent EULAR Congress regarding to clinical topics. And I'm very grateful as well for Dr. Podubny's guidance. As a recurring theme at the Congress in abstracts and scientific sessions was actual involvement in PSA. The general conclusion was that we need more data to reach a consensus definition. And that's why we wanted to highlight Dr. Morat's presentation about the answer provided by the Axis study on this regard. The Axis study is an initiative by Axis and GRAPPA with the primary objective of systematically evaluating the clinical and imaging manifestations indicative of actual involvement in PSA patients to develop a definition and a classification criteria. And if you can pass me to the next slide, we can see what the specifically objectives that were aimed to determine by this study was the frequency of the actual involvement in PSA patients and identify the frequency of active inflammatory lesions and structural change on imaging, and also to identify factors associated with the presence of actual involvement in PSA. And on the next slide, we can see how there were a total of 428 consecutive patients with PSA diagnosis who met the CASPER criteria and whose symptoms were up to 10 years of duration and who had not received any treatment with BDMARs. Of these 428, 19 patients were excluded for various reasons, leaving 409 patients included in the study. These patients underwent clinical, laboratory, and imaging evaluations that include X-rays, MRIs of the spine and sacroiliac joints. And after this, the local investigators made an initial diagnosis of whether the patient had actual involvement or not. Additionally, at the same time or parallel, a central imaging committee consisting of a radiologist and a rheumatologist evaluated the image without knowing any other patient data. And they were also asked if these images were comparable with actual involvement in these patients. And finally, no, please, thank you. And finally, no, go back, please, sorry. The local investigators were asked again, taking into consideration the information given by the Central Image Committee, if those patients had actual involvement or not. The results, now we can move on. They found that local investigators reported 37% of patients with actual involvement, while the imaging committee found that 23% of the patients had at least one positive image for actual involvement. The final diagnosis of the local investigators, taking into account the evaluation of the imaging committee, show 27% of patients with actual involvement at the end. On the next slide, we can see an image that summarizes quite well the clinical parameters in patients with and without actual involvement. And in general, 85% of the cohort presented with back pain, not necessarily inflammatory, being higher in the group with actual involvement. However, when discerning inflammatory back pain, it was significantly higher in patients with actual involvement. Similarly, HLA-B27 positivity and elevated CRP were more prevalent in patients with the diagnosis of actual involvement, and the family history of SPA was also slightly higher in this group. However, there were no difference in extraarticular manifestations such as uveitis or IBD, nor in the frequency of peripheral musculoskeletal manifestations as well. On the next slides, we can see the results regarding imaging evaluation. 14% of the cohort met the modified New York criteria, being significantly more frequent in patients with actual involvement, as well as radiological change in the spine. Regarding sacroiliac MRI, we can see in the next slide, almost 30% of the entire cohort had a compatible change, 70% in patients with actual involvement, and there was a higher proportion of structural change reported, 65% compared to active inflammatory change, 46%. As for spinal MRI, in the next slide, we can see 20% of the cohort had finding compatible with actual involvement that were more predominant, as expected, in the group with the final diagnosis of actual involvement, and the proportion of inflammatory and structural change were more similar than what we found in the sacroiliac joints MRI. So to conclude, actual involvement was detected in 37% of PSA patients after the initial evaluation and in 27% after the final evaluation. The presence of back pain, including inflammatory back pain, HLA-B27 positivity, higher CRP levels, as well as the prevalence of active inflammatory and structural change in the sacroiliac joints and spines, were associated with the final conclusion of the presence of actual involvement, and it was also shown that there was a trend toward overestimation of the presence of imaging changes indicative of actual involvement across all the imaging modalities. Continuing with the theme of actual involvement in PSA, which as I mentioned, as Fabian mentioned as well, was a hot topic at the Congress. I would also like to bring to your attention this abstract that was presented in the same session by Dr. Abreu, where the aim was to determine the proportion of AX-PSA among PSA patients and to identify clinical and demographic characteristics associated with actual involvement in patients that had a diagnosis of PSA or SPA plus psoriasis. And this was from the Portuguese Registry of Rheumatic Disease, or REUMA-PT. And this study evaluated more than 2,000 patients. 53% of them were female, with an average age at the diagnosis of 45 years old. And of these patients, 37% had the diagnosis of AX-PSA. And from these, 22% had exclusively axial involvement. And that is approximately 8% of all the patients that were included. The definition of axial involvement in this case was given by the physician reports or by suggestive imaging findings. And indeed, 30% of AX-PSA diagnoses in this study were made in this later way, mostly by the presence of radiographic sacroiliitis, more than 75% of these imaging diagnoses were made by this. And in the multivariate analysis, they show that HLA-B27 positivity and the presence of enthesitis were independently associated with axial involvement, as well as they could show that in this group of patients, there were a lower proportion of dactylitis, and smoking was found as a risk factor. The next slide now. Another recurring theme at the Congress was patients with difficult to treat PSA, both in scientific session and in the number of abstracts that were submitted to this Congress. And I bring to you this summary of the poster presented by Dr. Andre Ribeiro. This was a GRAPPA initiative to define difficult to treat psoriatic arthritis through the collection and the analysis of insights from GRAPPA members via an online survey between September and October 2023. And in total, 223 responses from 47 countries were included, primarily dermatologists and rheumatologists, of which 82% agreed on the need to have separate definitions for difficult to treat PSA and complex to manage PSA, characterized by the presence of persistent inflammatory activity for difficult to treat PSA and the influence of non-inflammatory factors leading to the treatment failure about complex to manage PSA. Similarly, more than 90% support or agreed on including objective signs of inflammation in the definition of difficult to treat PSA, especially regarding methods such as ultrasound and MRIs. Also, although there was no consensus on the inclusion of laboratory inflammatory markers. And regarding the treatment failure criteria, the response vary, but you can see as most of them favor the definition as failure of at least one conventional DMARD and 2 B DMARDs with different mechanisms of actions. So this survey underscore a strong consensus among GRAPPA experts on differentiation difficult to treat PSA from complex to manage PSA, emphasizing on the importance of including objective signs of inflammation in the definition of difficult to treat PSA. And lastly, this study that was presented by Dr. Fagni shows the result of the compact study on the progression of microstructural damage in PSA patients assessed by high-resolution quantitative peripheral computed tomography. This was a retrospective study that included patients with PSA that met CASPAR criteria with at least 2 peripheral CT scans of the distal radio and the second and third MCPs of the same hand, evaluating the presence of erosions, endocytes, bone mineral density, bone microstructure, and biomechanical properties. And they define microstructural progression as either the new occurrence or the increase in the size of erosions and or endocytes detected by the CT. And a total of 93 patients were recruited with a median follow-up of 40 months to a maximum of 10 years. This cohort was mostly male, age 51 years old, with an average age at the diagnosis of 45 years old. And they found that microstructural progression was present in 34% of the patients, mostly before the 3 years of follow-up. And the progressors having higher levels of disease activity measured by the numbers of tender and swollen joints, and higher levels of activity disease scores as DAS28 or DAPSA28. And they also found significant time DAS28 interactions that you can see on this figure, where the green dots correspond to a DAS28 of 5.1 or above, and the red dots corresponds to a value of DAS28 of 2.6 or less. And you can see how there is a faster loss of cortical and trabecular BMD over time with the increasing DAS28 on the first 3 figures on this. And in the next slide, we can see how at baseline, patients treated with BDMARS had a lower bone mineral density, probably due to higher disease activity that led those patients to receive BDMARS. However, over time, these patients show a slower decline in the cortical and trabecular BMD compared with these untreated patients. Untreated meaning no BDMARS, of course. And at 40 months, patients that had been treated with BDMARS had a higher BMD and a greater number of trabecular than untreated patients. So this data can help us to emphasize the critical period for the initiation of early BDMARS treatment in order to, we hope, preventing microstructural progression in PSA. So in summary, I hope these findings are useful for your clinical practice. Thank you so much for your attention.
That was wonderful. Thank you, Daniela, for that great presentation. So now we will open it for a Q&A. Maybe I'll start with a question about the first abstract that you presented about the AXIS study. So I'm a dermatologist, right? So I was trying to understand, first you did a clinical diagnosis, then you had the results from imaging that were blinded to whatever the clinicians were assessed, right? And then clinicians, again, using the MRI information, made the final definitions of who had axial disease, right? And then you saw a drop from 37 to 23% in imaging to 27%. And so what happens in that third step when the clinician takes the imaging results, right? And I understand, I can see how the imaging is not supporting the diagnosis, and then you drop from the 37% to 27%. But that 4% that goes up from imaging to clinical, how is that interpreted by the clinician? And here I invite everyone who's expert on this.
Yeah,
the question makes sense.
Yeah. So it might have been a little bit confusing our difficult way towards the best possible estimation of the truth. We were trying to come to the truth as close as possible, and that is why we had several levels, so to say, of evaluation. What you saw at the end is probably the best possible estimation of the truth. So what happened at the beginning? That was a clinical diagnosis taking all information which was available, including imaging information, into account.
They even had imaging from
Yes, of course.
records.
Yeah, they had complete set of images, so they evaluated images by themselves. And then we realized, even among rheumatologists and radiologists, there is a substantial level of uncertainty in terms of what to interpret as spondyloarthritis or psoriatic arthritis manifestation. That is why we installed this central imaging evaluation committee to homogenize evaluation, to provide an expert evaluation. So that step was considered as a help, as an aid to investigators, to the rheumatologists dealing with their patients. What happened then between the first and the final evaluation was that local investigators looked at feedback provided by experts, by imaging experts, and they could change their mind, but they could stay with their initial opinion. So and you saw that in some of the cases they revised the initial classification. That is why it went down. What we see, so the bottom line message here is that we face a substantial overdiagnosis of inflammatory problem in the axial domain. And this is true not only for psoriatic arthritis. The same story is about axial spondyloarthritis. We were also huge issue with overdiagnosis. So we think that giving some answers in the future on what are the specific features of psoriatic arthritis on imaging would really help to differentiate better between truly inflammatory involvement and rather mechanical degenerative changes.
Thank you, Dennis. And I see the other Dennis McGonigal has his hand raised.
Hi, Dennis.
Yeah, hello everyone. Can you hear me?
Yep,
Yeah.
perfect.
Oh, good. I had trouble with audio earlier. Hi, yeah, Dennis, coming back to you. This study, we know that age per se and obesity may link to mechanical driven bone edema changes.
Yes.
We're missing a control group, which is going to be a huge issue interpreting this data. And my second comment is, you call it they're overdiagnosis, but a lot of these patients have inflammatory symptoms, as the Barliakis abstract in the last presentation showed. So these people with good going peripheral arthritis and good going inflammatory symptoms and raised BASD scores, 60% had negative imaging. That doesn't mean they don't have inflammation. It's just that you can't see it. So I would strongly argue that maybe we're not overdiagnosing. It's just that we can't see the soft tissue centric inflammation, but we're good at seeing the osteotic centric inflammation. So those are my two issues. Thank you very much in advance.
Yeah, thank you, Dennis. Yeah, you're right. So we don't have, we haven't recruited a group of patients with primarily mechanical issues, but due to this differentiation within the cohort, I think we can make a comparison between inflammatory problem and a truly mechanical problem. And yeah, we have discussed in the last times the issue of maybe not 100% sensitivity of MRI, especially for inflammation not occurring in the bone. I think it might be the case, but my impression, and I didn't mention that, we had another level of truth there. So there was a central clinical evaluation. So 3 of us from the committee looked at all the cases taking clinical information, imaging information into account. So I reviewed virtually all patients in this cohort, and I had an impression that there were only few cases where there was big discrepancy between MRI findings and findings on X-rays. So on X-rays, I had an impression that there is ossification that should be inflammatory or post-inflammatory, but MRI was clean. So this may be the case, but as I said, the numbers are still to come. But my impression was that it is not very common. So my take-home message out of this was, in patients with psoriatic arthritis, like in any person aged above 40, mechanical problem is substantially more likely than inflammatory one.
Thank you. Yes, and I think it's such an important effort that here the GRAPPA group and ACES we're doing together, because I think having this data and getting a better idea of what really actual PSA is will really help us in the future designing studies, but also in the clinical context. And this is also coming back to the question from Jeff. He's a patient research partner from the GRAPPA network, and he's asking, and I think it's a very important question. I think you already indicated this, Dennis, but should more training for interpretation of the imaging be provided, given for general practicing rheumatologists around the globe? Because even those ACES and GRAPPA experts from around the globe seem to overinterpret, overdiagnose the imaging findings. So I think this is a very valid point, and maybe you can elaborate on this, Dennis.
Yes, absolutely. And I think what was quite eye-opening, and I think it will be very important in the future. So in primary axial spondyloarthritis, we're concentrating on sacroiliac joints mostly, and this is I think it's perfectly right, because normally in primary axial SPE the disease starts there, but for psoriatic arthritis we need to consider also the spine, and spine is very tricky. Spine is difficult. We need to learn how to differentiate it better and to train our colleagues.
And also the part that the other Dennis just mentioned, especially this is a bit more tricky in the PSA population that tends to be a bit older, that tends to be obese, where mechanical issues that are harder to differentiate from the PSA pattern is more challenging. So I think this is very important, and I think here efforts that result out of the ACCESS study giving a better indication what should be really counted as actual manifestations by imaging will be really valuable for the treating clinicians.
Great.
And
you want to comment something else, Fabian? Go ahead.
No, this was only my question also for the Rheuma PT. Daniela, maybe you could also, because there were some differences seen, and here I was having a little bit, I mean, the numbers were nice and great, but also we were not 100% sure how the treating clinician were coming to the result of the patients having actual disease, right? And maybe you can just elaborate on your thoughts on this and the potential bias of the Rheuma PT data that were presented.
Yes, the definition they took to assess the diagnosis of actual involvement in these PSA patients were based solely on the reports of the physician that was treating those patients, or in the case they could find imaging that were compatible with these findings. So yes, we don't have that control of how the diagnosis was made, but I think it's like the current practice, and the prevalence of these diagnoses were pretty similar to the first assessment of the local investigators on the ACCESS study that was around 37% in both. So I think that reflects a lot how we as practitioners made our diagnosis, although the populations were different, of course, and the methods were different.
Yes, thank you, Daniela. And also you touched on the difficult to treat topic, and also the ambitions from GRAPPA to come up with a definition of what is difficult to treat, and you showed that there's quite a homogeneous consensus that we need to split between complex to manage as the rather broader concept, with different topics contributing, like comorbidities, hypersensitization, maybe even access to treatment, and the truly treatment refractory despite different modes of action of difficult to treat. And I think this was coming out quite clearly from this survey within the GRAPPA membership, and also that objective signs of inflammation need to be present. And I think also highlighted where we have to do some work to find a consensus, how many treatments need to be administered before we can call a patient difficult to treat. And here, I think this is really important also to include the patient perspective. Within the working group, we have patient research partners, and also we just finished a survey of PSA patients from around the globe with almost 600 responses, and these are currently being analyzed so that we will have a very strong patient involvement also when coming up with a proposed definition of really what difficult to treat is. So I think it was really interesting data that you presented, Daniela. Thank you so much, Dennis, also for supervising and coming into the discussion. And without any further delay, I think we will focus now on the basic science, translational science. And here it's our pleasure to introduce Vinod Kumar, and who was supervised by Dennis McGonigal. And I think it will be really fantastic to finish up with the basic science topics now. And Vinod, who is an assistant professor in the Department of Dermatology from India, and also a very active young GRAPPA member, and having him supervised by Dennis McGonigal, one of the GRAPPA steering committee members and the leader of the enthesitis expert from around the globe. And yeah, really looking forward to the presentation. Vinod, the stage is yours.
Yeah, thank you. Thanks a lot for the nice introduction. And thank you, GRAPPA, for giving this opportunity to present over here. And definitely Dennis to help me summarizing all the findings. So the first, these are the disclosures. And the first abstract I'm going to present is from the Dennis lab that is presented by Nicolette. And here it is related to the investigation of normal HSCL IL-17F cell subsets, their protein expression, and the impact on the HSCL mesenchymal stem cell function. So as we know that IL-23 and IL-17 axis is very well known mediator of the inflammation, but in the axial diseases, inhibition of IL-23 doesn't help that much, but the inhibition of IL-17A and F have more benefits. So this in this study, they have mainly addressed three questions. First, that does ethicitis associated with IL-17F also along with IL-17A, and is this IL-17A and F production is dependent on IL-23 or not? And third, that how does IL-17A and F alter the epithelial stromal cell function and their behavior? So in the next slide, if we see the first question to see whether there is the expression of IL-17F, they have isolated the they have used the peripheral blood, and they have isolated the cells from the periaxial bone, and they have stimulated these cells by using CD3 and 28 beads, and then they have done the flow cytometry, and they found that if we induce these cells, there is an increase in the production of IL-17F along with IL-17A. And but this on the right hand side, the CD8 cells, they are unable to show the increase in the IL-17F along with the A. They also did the site of analysis, and the graphs indicates that these are the CD4 and gamma delta TCR cells who are producing more of the IL-17F compared to the CD8 positive cells. So in the next slides, they have tried to answer the second question, that does this IL-17 and F production is dependent on IL-23 or not? For this, they took these epithelial T cells and they stimulated them with CD3 and 28, and then they have added IL-23, and then they have added inhibitors of IL-23, and they also use IL-23 alone. And as we can see in the right graph, here is IL-17F. we mark with the red lines that yes, that the stimulated cells are able to produce IL-17F, and when we when we added IL-23, there is a more increase. The amount of IL-17 is get more increase, and when they inhibited the IL-23, there is a decrease in this level. But when they have used only IL-23 to stimulate these cells are unable to produce or secrete IL-17F. So it shows that the IL-23 can't induce the IL-17F expression, but it can enhance the IL-17 expression once it get induced in the cells. And to answer the second question, that whether this IL-17F can alter the stromal cells and their osteogenesis, they have isolated the epithelial stromal cells, and then they have incubated them or stimulated with IL-17A and F, and they observed that they don't have any effect on the osteogenesis, but they can increase the inflammation. And the cells which are the cells which are primed with TNF, they can produce more IL-7. They can produce more inflammation, and like CCL20 compared to the other type of cells. So it shows that yeah, there is a need of priming of these cells. Like TNF can prime these cells, and then IL-17A and F can induce more inflammation. And in the next slide, if we see what are the key findings of this study, that this is the first study that has defined the role of IL-17 in the enthesis, and that they have shown that yes, these cells, the T cells which are present in the epithelial can produce IL-17 along with IL-17A, and this IL-17F production is independent of IL-23. They can't induce it, but they can enhance this. And this IL-17F don't have any modulatory effect on osteogenesis, but it can increase the inflammation if the cells are synchronized previously with some other inducers. And this is a question that we can discuss, I think, later on. So we can go to the next, yeah. So this abstract is also from Dennis' group. So here they have studied that a healthy epithelial immunoregulation, mainly mediated by CD39 and CD73 adenosine pathway. So this work depends upon the fact that in the epithelial tissue, there is a rare presence of Treg cells. So when there is no Treg cells, then the mesenchymal stem cells, which are residing inside that micro niche, can acquire the Treg type of phenotype. So the question they have designed was that, does epithelial soft tissue and the bone mesenchymal stem cell express these ectonucleases? And can these ectonucleases expression mesenchymal stem cell inhibit the T cell proliferation like the Treg cells? Does these mesenchymal stem cells share the same immunomodulation pathway that of the Tregs? And if we inhibit this pathway in these mesenchymal stem cells, can they modulate the immune response or not? To answer this question, the next slide they have first they have isolated the non-T regulatory T cells, and they have isolated the stromal mesenchymal stem cells, and they looked for the expression of CD73 and 39, and they shown that yes, in the stromal mesenchymal stem cells there is increased expression of these two markers. And secondly, to check whether these stem cells can inhibit the T cell proliferation, they have done the co-culture experiments where they have isolated the non-T regulatory T cells. They stimulated them and then co-culture with mesenchymal stem cells, and they observed that yes, these mesenchymal stem cells like Tregs can inhibit the T cell proliferation. And in the next slide, they tried to answer the third question, that is that these mesenchymal stem cells are behaving like Treg, and they share the common pathways. They did the RNA-seq for these mesenchymal stem cells, and if we see there is a equal presence of Treg activated pathways like IL-10, IL-33, CTLA4, PDL1, and we can see many more IL-6 and these two ectonucleases expression also. And to check that, to confirm this further, they have inhibited the expression of CD39 and 73 by using the POM1, that is the polyoxo tungstate, and the APC1, that is a ectonucleases inhibitor. And they able to show that yes, that if we inhibit this pathway, there is a decrease in all the signaling pathway or the that are activated in Treg. So, and they also done the co-culture experiment by using these ectonucleases inhibited mesenchymal stem cells, and they are able to show that yes, if we inhibit this pathway, the immunosuppressive or the T cell proliferation inhibitory effect or the property of this mesenchymal stem cell get disappeared, and they are unable to inhibit the T cell proliferation. So in the next slide, if we can summarize the finding of this abstract, that yes, the resident epithelial stromal tissue and the bone mesenchymal stem cells have activated CD13 and 73 adenosine pathway, and these mesenchymal stem cells can act as the Treg cells, and they can be targeted to alter the localized immune response for the therapeutically. And these are the questions that we can include in the discussion. So this is the third abstract where the author tried to summarize that if the sulfingazine 1 phosphate and its receptor can act as a biomarker to predict the damage and inflammation in the patient with the psoriatic arthritis. So this study based upon the fact that this S1P and S1PR, the receptor axis is very is very helpful in determining the interaction between immune system and the bone homeostasis. This axis mainly regulate the lymphocyte infiltration and their proliferation and the growth. It can also make a balance between osteoclastogenesis and osteogenesis. So their question was that does this axis associated with the disease activity, bone mineral metabolism in the patient with psoriatic arthritis. So in the second next slide, they have for this study they have included healthy controls, that is a 21, and psoriatic arthritis patient, they are 43. So these are their the clinical features. So we can go for the next slide. They have measured the levels of SP1 by using ELISA, sclerostin, and Rankel OPG ratio, and they have done the comparison, and they found that yes, in the PSA patients there is an increased expression of these three biomarkers, and these are majorly driven by the the psoriatic patient who has disease persistent for more than 1 year. Means the stable psoriatic patient, but the patient who are very early or the onset of the disease, there is no association of these markers. Then they did the correlation and analysis, but they didn't find any strong association of these SP1 and SPR expression with the sclerostin or the disease activity. But they found that this OPG level is strongly associated, but they are strongly and negatively associated with the disease activity. So it's a we can go to the next slide. So it's mainly in the Achilles. So they have shown one graph in their abstract there where they have shown that in the Achilles there was increased expression of S1PR, and it associated with the inflammation over there. So we can go to the next abstract. So this is another abstract where they have shown that they try to show the clonic sharing of CD8 positive T cells link skin and joint inflammation in the psoriatic arthritis. So here the authors want to show that there is a sharing of the immune cell phenotype between between the cells which are present in the synovial fluid, synovial tissue, and the skin of the psoriatic patient. So they have addressed the two questions. First, that is synovial fluid is in the approximate proxy to investigating the inflammatory T cell infiltrate in the synovial tissue. And second question was this: does the paired sample of the skin and synovial tissue and fluid of the patient with the psoriatic arthritis share the same immune profile. So to answer the first question, in the next slide, they have to taken a psoriatic patient and the rheumatoid arthritis patient 7 and 1, and they did the TCR sequencing by using the single cell RNA sequencing, and they concluded that yes, there is a striking similarity between the immune cells which are present in synovial fluid and the synovial tissue, and the frequency of these cells is also similar. So from here, they have concluded that yes, the synovial fluid can be used as to investigate the inflammation or immune alteration that is happening in the synovial tissue. So in the next slide, they have answered the second question, that does the skin sample, that the skin of this patient share the same immune profile that of the synovial tissue and fluid. They did the this single cell RNA sequencing, and they have analyzed the shared clone between these two sites, and they have found that the 155 CD8 positive clones were shared among between skin and joints, where the 13% are coming from the skin and 8% from the synovial tissue and fluid. And most of these cells are cytotoxic and inflammatory. And if they also look for the CD4 positive cells, so there are 46 clones which are shared between skin and tissue and fluid, and the 6% are coming from the skin. But they also look for the type 17 CD8 cells, that is a tissue resident memory cells, and they find that they didn't give the percentage, but they have mentioned that they are enriched in both the sites. But the difference, striking difference, was that the cells which are present in the skin are more IL-17 producing compared to the one which are more inflammatory in the or cytotoxic in the synovial tissue and fluid. So if we summarize this study, that the T cell expressing identical TCR and with similar phenotype are present in both the sites. Share clones are more cytotoxic and pro-inflammatory in the skin, in the synovial fluid and tissue compared to the skin. And they also shared that yes, in the psoriatic arthritis, the T cell infiltrate in the skin and joints are linked. So this is a. So I think we are finished with this. All thank you. Thanks a lot.
Thank you so much, Vinod, and also Dennis for presenting this. Just to start the discussion, and really happy to get any questions also from the audience. For the first abstract that you presented with differences of IL-17A and F, what are your explanations or potential thoughts about clinical implications? Do you think this will also then affect treatment response in the different modes of action? What is your take on this, to the two of you?
Vienna, do you want to go first? Everyone, there was a very good session, and it's hard to get all the good slides, and we had 2 presentations at the psoriatic session, so it was easy for me to share the slides with Vienna. We need to give a special mention to the abstract from Erlangen, where they did serial biopsies of the lateral epicondyle in psoriatic arthritis, showing IL-17A producing cells at the enthesis going down after therapy. So Vinod, as I say, I had the slides because my team presented. So Vinod, do you want to comment first as a dermatologist, given that bimekizumab beat secukinumab in the head-to-head in the skin?
Yeah, I think both these molecules are working through the same pathway, but if they are expressing differently, maybe at the genetic level, there are the certain changes at the epigenetics that might be playing a role over expressing these 2 different forms. So I think targeting, as we have seen, that if these cells are primed before, they can, enhance the inflammation more when they get exposure of either IL-17 or IL-17A or F. So I think it's better to target the both. And I think it also varies from disease to disease and maybe the location to location. Yeah, Dennis, you can add more,
Yeah, so from my perspective, what we found at the enthesis was analogous to the skin, in that there was more inducible IL-17F protein than IL-17A, but we know that 17A engages the 17 receptor much more strongly. So we found that similarity with the skin. And of course, unlike the skin, we have mostly normal tissue. So we didn't see the tissue resident memory IL-17A or F producing T cells that are well reported in the skin, because our tissue is normal tissue where we then activate the T cells in a non-antigen specific way. So that's a bit artificial. But it's interesting that we have to hold our hand up and say, thus far, the IL-17A/F dual blockade is not buying extra efficacy in the joint, compared to the skin, based on the available data we have. And we saw that for sonelokimab as well, where there was a reference adalimumab arm thrown in earlier, and it looked very similar to the bimekizumab adalimumab reference arm in B complete. And then when you extrapolate across to Exceed and Spirit head-to-head with secukinumab and ixekizumab respectively, in the arthritis, there was no obvious difference between blocking 17A or TNF. So this story, although we're seeing the same molecular signature and kinetics at the enthesis, the joint responses are not panning out the same way. And the other thing I'd comment that Vienna showed, and this has previously been reported in the rheumatoid synovium, is that IL-17A and TNF, or IL-17F and TNF, are synergistic for stromal cell activation. And in our case, we demonstrated high levels of CCL20, which should recruit CCR6 positive IL-17A producing T cells. So we do see this synergy between A and F with TNF, but not with each other. So my feeling is there is a group of patients that we need to figure out who they are, where the addition of F is actually making a big difference. And the reality is our laboratory research is trailing behind the clinical trial translational observations by at least a decade. This is the first description of 17F at the enthesis. Yeah, so it's a few thoughts there.
Thanks for your insights on this, Dennis, and also to a bridge to also axial spondyloarthritis, where it's quite similar, right? It's not only from the joint response in PSA, where the data is for dual inhibition of IL-17A and F, but also for the axial skeleton from the AXPA studies. The data is quite convincing, but it's in line with all the other modes of action that we know. So I think there seems to be a difference from MSK manifestations to skin disease on expression and influence of IL-17A and F inhibition. And also because we have spoken in the clinical data about transition from PSO to PSA, and I think it would be so valuable to have better biomarkers for really PSA in the early disease, or maybe as a risk factor in PSO patients developing PSA on the later run. And you presented, Vinod, on the sphingosine 1-phosphate, and also highlighted the quite tricky question: might it be a novel biomarker? So what is your take on this?
I think as go ahead. Actually,
no, go ahead. No.
Yeah, me and Dennis was like discussing trials later that there is that the people are targeting this pathway therapeutically, like in the ulcerative colitis and in the multiple sclerosis, they are using and targeting this axis. So it holds a very promising, I think, translational value. But according to this study, like it's only associated with the Achilles. So I'm not sure that whether in the transiting phase, how much I'm not aware that much of the literature that how much has been done in the transition phase for these markers and this pathway. So Dennis, if you have some idea, you can add more into this.
Yeah. Just to highlight, we're more familiar with onizumab, which has a license in ulcerative colitis, and fingolimod, which is a license in MS, antagonize this pathway. And the issue is the sphingosine 1-phosphate receptor pathway has protein and multifaceted impacts, including on osteogenesis. And I didn't know this, and this is why I thought it was very interesting for Vienna to highlight it to the group, how this might be linked to markers like SOST, which encodes for sclerostin, which obviously the anti-sclerostin antibodies licensed to prevent osteoporosis, and given the bone phenotype and psoriatic arthritis, this abstract, I think, was of general significance to say to us, oh, this is an interesting one. And I think beyond the therapeutic tractability of this pathway in the wider SPA spectrum, if we need more targets, there's this interesting issue around bone. And I think we need more data on this. This would be the first in kind study. Yeah, Vinod?
Yeah, sure. I agree with this. We might need more data to what is a good axis, like if this is a.
Thanks, both of you. Yeah, maybe also to bridge back to Dennis, to Toronto, because I know that you also, as you were today, we heard about the access study, and here there will also be a biomarker project associated, right, to access. Can you elaborate a little bit on the status and what is planned here?
Yeah, I think the project is still ongoing. We were not directly involved in that, so it goes in parallel. So that they're still collecting data to my knowledge, quite close to the concluding that. Yeah, I'm carefully optimistic if we can really find something that would be the biomarker for XL disease. So it would be pretty challenging for sure.
Okay, and maybe also another question, because the composite study is or composite outcomes are very important, and we heard that here the antithesis plays a major role also with IL-17A and F inhibition. And Dennis, going back to you, do you think that here there will be specific trials also assessing anti-citus as the primary outcome, and maybe also focus on the biomolecular structure on this in the future?
Well, of course, Novartis, who did the study, the Achilles study, with 200 people, didn't meet the primary outcome because the placebo response was nearly 50%, in keeping with the fact that entheses get injured and repair and make new bone. So it's a very difficult structure to deal with, and it's very hard to measure. And I don't think any company in their right mind would do such a trial at the moment until something better happens. And then you can say, well, what about imaging? So, of course, in the Achilles study, they did use MRI imaging, and it did not show any difference with the placebo arm. So this is the problem with the relatively avascular structure. And most of the immunology that Vinod showed you is from the bony anchorage side of the enthesis, where there are more immune cells, so we can readily measure the inducible cytokines. We can also detect them in the soft tissue, but it's usually at transcript level because the cytokines are not in the hundreds of picograms per mil, but in less than 10. So it is a very difficult question. And I think, as Dennis alluded to there, a biomarker in axial disease is tough because much axial disease is enthesial based, and it doesn't drive a systemic response best detected by CRP or ESR. So if they don't go up, it's hard to know what other markers are going to selectively appear in the serum. So it really is a very difficult area. Yeah. Don't mean to be a cynic about enthesial research, but it is difficult to measure.
Sure. Arnon, I see you here also in the group. What is your patient perspective? Because I mean, we heard today about treatment, and we heard fantastic data of new modes of action coming to the picture. We heard clinical topics. So what was the most fascinating of the topics presented today for you?
Well, thank you for questioning. First of all, I apologize for not being able to join the first part, the first lecture, but referring to what I did here, I was just trying to listen and to analyze what I heard. I think the comparisons are very interesting, but we all have to remember, and I know this because I'm coming also from the scientific world, the statistics are the best liars around. So we should be very careful when we deal with statistics. Now, especially when we deal with this kind of disease, which has a lot of comorbidities and a lot of complications. And I think if I would have the possibility to add the researchers presented over here, I would go and ask the caregivers and also the patients, why did they change the treatment, the medical treatment, if they had changed it. Because you're putting one against the other, different kind. For example, if I refer to the last lecture, you're putting one against the other, different kind of treatments. But both physicians have changed. But physicians have changed treatment to patients that did not manage to go along with a certain type of treatment. So I think this would be a very interesting question, which you can ask your environment. Why will treatment change? This is one thing. The other thing is, we didn't mention here, I didn't see mentioning comorbidities caused by different medications. Now, this is something very difficult to do because we don't know if comorbidities are due to the disease or the development of the disease or to the treatment or anything else. But I think that if we can go into these issues, it will be very helpful both for you and give very interesting points to the patients in order to understand this. But I think that the issues that I heard were very interesting issues. And the last comment to do, if it was possible to present before your presentations or within a very short presentation, lay presentation, to explain what was behind the research, I think it would add a lot to the presentations themselves. So thank you for your time.
Thanks, Arnon. Okay, everyone, I think we are already out of time, and thank all of you for participating, for your interest, joining today. Thanks to the fabulous young Grappians for the brilliant presentations and the senior GRAPPA members for the supervision. I really enjoyed it a lot. I learned a lot, and I think it will be definitely continued. And we already have the date for the highlights from the EADV conference, which will take place on October 9th. And I'm really looking forward also being able to get updated about the newest research from the dermatological perspective. And yeah, thanks to you, Lourdes, for co-hosting today. Thanks, Annie Spengler from GRAPPA administration. And thanks, everyone. Have a wonderful rest of the day. I really enjoyed it, and I hope you too. And stay tuned and stay curious.
Bye, everyone. Thank you.
Thank you.
Thanks, guys.
Thanks, Ed.